see their problems through your discerning eyes. Guide us, Lord, and keep us in everything we do, for you are the great physician, and we long to be like you. Amen. All right. Now, tonight, we're going to be discussing resilience, reflection, and responsibility, laying the foundation for mental health and ethical practice in medicine. I am Dr. Aldith Buckland, the Vice President of the Association of General Practitioners of Jamaica. And this webinar is being hosted by the Association of General Practitioners of Jamaica and Medimpex Jamaica Limited. It is our annual mental health and ethics seminar. So again, welcome, and thank you so much for taking the time to join us for this timely and essential discussion. We focus on two critical aspects of modern medicine: our mental health and the ethical challenges we face as we balance care for others with care for ourselves. There are rising challenges in medicine. You know, for the past few years, we have been placed on an unprecedented burden on healthcare professionals. There have been increased workloads, emotional exhaustion, evolving patient needs have exposed deep vulnerabilities in our systems and within ourselves. Burnout, compassion fatigue, and moral distress are no longer rare terms. They are realities many of us face. Research shows that mental health issues among physicians continue to rise, with growing concerns in both institutional and private settings. The impact on care and the caregiver. We often speak of the importance of patient-centered care, but how can we truly provide that if we ourselves are depleted? Our mental health directly affects clinical decision-making, empathy, communication, and ultimately patient outcomes. Yet, the culture of medicine has long discouraged vulnerability, and even today, many of us struggle silently. Ethics and physician well-being. There is an ethical dilemma in this struggle. How do we honor our duty to patients while maintaining our own well-being? We often find ourselves in a dilemma. Should we keep working when exhausted, cover another shift, skip lunch to accommodate just one more patient? While altruism drives our profession, unchecked sacrifice can lead to diminished care and personal harm. We do have a responsibility to ourselves and others. Our ethical responsibility extends beyond patient care. It includes responsibility to ourselves, our families, and our colleagues. We must normalize practices that promote wellness, reflective practice, mindfulness, peer support, and seeking help when needed. These are not signs of weakness, but essential acts of professionalism. Building a culture of wellness is a must. Change must be both individual as well as systemic. Institutions must provide support systems, fair workloads, and wellness resources. As individuals, we can model healthy behaviors, set boundaries, and advocate for ourselves and others. Ethical leadership begins with example. So the agenda we have for this evening, we're going to explore these issues in greater depth. Dr. Winston Delahaye will share strategies to prevent burnout and compassion fatigue among healthcare providers, and Dr. Alverson Bailey will address the ethical complexities of self-care and maintaining professional duty. Your role in this meeting is very important. I encourage each of you, and I also encourage myself, to engage fully. Reflect not only as a practitioner, but as a human being deserving care and consideration. Let now be a moment of learning. Let now be a moment of reflection. And let now be our recommitment to our well-being and ethical grounding. Thank you, and let's begin. So at this time, we're going to have a very special person coming to us. And it is going to be our sponsor, who is going to bring welcome. Please,
Thank you very much. Thank you very much. My name is Paul Dennis, Medical Representative Supervisor. Can you all hear me? Can you hear me? I'm not sure.
Paul. Yes, Paul, I can hear you.
Okay, great. Good evening, ladies and gentlemen. Medimpex is thrilled to once again partner with the Association of General Practitioners in Jamaica to host its annual ethics seminar. Special thanks to Dr. Donald Gordon, President of Agpj, Mrs. Lynn Thomas Hyatt, the Secretary, Mr. Samuel Heron from Oldgate Solutions, and Dr. Aldith Buckland, our moderator. A warm welcome to all our esteemed professionals who have joined us. Thank you for your tremendous support. The webinar is titled Mental Health and Ethics. As you know, Medimpex markets and distributes several products related to mental health, such as your Cavinton, your Palixid, your Stimulotan. We are committed to working with you to provide quality pharmaceutical care for your patients. As our motto says, first-class products for healthy living. At this time, I would like to introduce the hard-working and dedicated medical representatives that I supervise, starting with Mrs. Lisa Hubbard, Mrs. Cheyenne McGoo, Miss Sasha Dixon, and Miss Melanie Miller. Once again, a warm welcome to all of you, and thank you for joining, and I wish you a productive and inspiring time during this seminar as we listen and interact with our speakers. Thank you very much.
Thank you so much.
Exceptional healthcare starts with delivering excellence and customer satisfaction. Medimpex Jamaica and Medimpex West Indies are today leading pharmaceutical industry players in the Caribbean region. Proudly based in Jamaica for over 40 years, we aim to improve the quality of life of West Indians. We deliver world-class healthcare products that meet the most stringent international standards of quality. With more than 350 items to choose from, our goal is to provide first-class products for healthy living.
Over to you, Sasha.
Good evening, everyone. My name is Sasha Dixon, and I am a medical representative at Medimpex Jamaica Limited. It is my great pleasure and privilege to introduce our distinguished guest this evening, a man whose extensive contributions to psychiatry, addiction treatment, and national health leadership have had a tremendous impact both locally and internationally. Dr. Winston Delahaye is a consultant addiction and general psychiatrist at the University Hospital of the West Indies and senior lecturer in psychiatry at the UWI Mona. He's a former deputy dean in the Faculty of Medical Sciences, UWI Mona. He completed his MD at the University of Pécs in Hungary, his postgraduate degree in psychiatry at the UWI, his master's in public health, and a Fulbright scholarship in substance abuse at the Johns Hopkins University. He's an internationally certified addiction professional and a global master trainer of trainers in the treatment of substance use disorders. Dr. Delahaye is a member of the Medical Council of Jamaica, past Chief Medical Officer in the Ministry of Health, past President of the Medical Association of Jamaica, past President of the Jamaica Fulbright Alumni Association, past Union President at the UWI, and past President of the Jamaica Psychiatric Association. He's a past Chairman of the Bellevue Hospital Board of Management, past Chairman of the Board of Supervision in the Ministry of Local Government, and past Deputy Chairman of the National Council on Drug Abuse. Dr. Delahaye established the medical cannabis unit in the Ministry of Health in July 2017, supervising the registration of 43 medicinal cannabis products in Jamaica. He's a founding member of the Caribbean Psychedelics Association and a former captain in the Jamaica Defense Force. We are truly honored to have Dr. Delahaye with us this evening. His exceptional leadership, wealth of experience, and dedication to the advancement of mental health and substance use treatment continue to inspire us all. Please join me in giving a warm welcome to Dr. Winston Delahaye.
All right, thank you very much. Very kind of you. Let me first thank our president and his team for putting on what I think is an excellent evening. Very important, very critical. I must thank Medimpex. As you're all aware, Medimpex is Hungarian originally, and Hungary is responsible for my career in medicine. In fact, having become fluent in Hungarian, and I still remain, I'm very happy to say that the stimulaton you use, that box was designed by me, all of the literature translated from Hungarian in the packet insert, which we recommend that patients do not read in too much detail because they're going to see side effects that they then have, you know. But an excellent country. I must point out that strictly speaking, I'm an exposed individual. So this is a silly season. We have an election coming up. I have a history of engaging in politics, albeit for a brief period. But the point I want to make is none of my comments are aimed at the current administration or any other administration. But of course, a subject like this, we must make mention of some of the systems in place or not in place. I wouldn't want to be misquoted. I have no history of speaking inappropriately. So let's just ensure that that's done. In fact, that concept of exposed individual, if you are going through London, for example, have a military history, there are times you get asked, do you have any knowledge of weapons? You tick yes, you're on a red light. Do you have knowledge of automatic weapons? You tick yes, having served in the JDF. So I'm on a red light. So when I go through London, my connecting flights must be 4 or 5 hours away because I am going to get stopped. You get stopped and you produce a Jamaican passport. That's a double whammy. But thanks to everyone, a very important topic. There will be some overlap, and it's a pleasure to be on this platform with Al Bailey, my friend of over 20 years. We both served in the Medical Association of Jamaica. And as I pointed out, some overlap, but we've been presenting for a number of years. So I'm very sure that between us, we'll be able to handle that. So the title of my presentation, Promoting Mental Health and Wellbeing for Healthcare Providers, and then we'll cover some strategies. So just to give you a broad overview, the problem then is the fact that healthcare providers face heavy workloads and emotional strain, leading to burnout, and I'm going to drill down into burnout and compassion fatigue, and there's an impact resulting from that, which is that these conditions harm provider well-being and compromise patient care quality, which we wouldn't want, given the Hippocratic oath that we took. So the focus then is on improving your well-being, making time for your own development, very important, because it's on you. Who else will if you don't? It must begin with you, and helping yourself while helping others. And that's very important. So let me just drill down into burnout, which is a phenomenon which has existed at all times and in all cultures. In fact, Moses' father-in-law, Jethro, in Exodus 18, and a number of us here are familiar with that kind of history. His leadership was discussed in Exodus 18, verses 17 and 18, where he was advised to share the burden for fear that it's not sustainable. And both he, Moses, and the persons he was helping will burn out. In fact, pastors go on to speak of the awareness of Elijah. That's Elijah being burnt out from way back then. So burnout, just for clarity, is a psychological term which refers to long-term exhaustion and diminished interest in work. There is a Bible that we use, for lack of a better word. This side of the world is the DSM-5 text revised version currently. I was trained on the DSM-4, but they move every 6 or so years. It's a recognized illness as burnout in the ICD-11. That's the International Classification of the Diseases, which is the other version of a Bible, for lack of a better word. Now, in its 11th edition, in the DSM-5 TR, it's specified as factors influencing health status or contact with health services. So it is there, just not as a specific diagnosis at this time. The point I'm making is it's a legitimate diagnosis, so you can have a sick leave if it is that you want to specify that says burnout is the diagnosis. So that's a chronic state of being out of sync with one or more aspects of your life. I'll go on to highlight some of those, which results in loss of energy, enthusiasm, and confidence, and where your physical health and your mental well-being will likely deteriorate. The main driving force is stress, and not a physiology class this evening, but you're all familiar with the HPA axis. That's your guy. That's the guy creating the problem. And we can't exist without our HPA axis, but it can go out of control, the main guy there being cortisol. Just to point out some life events which we know, I just want to share with you, there are some things we know in psychiatry which are very clear, all the relationship things. So this is a list, it's called the Holmes and Rahe scale, ranking stressors from 100 down, and top of the list would be death of a spouse, and then comes all the relationship things, getting married, getting divorced, marital separation, all those things, certainly higher than 50. Hovering around 60s, 70s, the divorce, marriage in itself, 50, and so on. So the significance of this slide is with this kind of knowledge and the presentation of the patients, you're able to determine what they're really faced with, which is what we're discussing. All the health problems we manage are exacerbated by stress, bar none. I've highlighted depression because that's the main one that comes up. It's the most costly illness, just generally and globally, and it would include here. Why would we be different? We just don't know. So this burnout we're talking about is measurable. A landmark study was done by Maslach and Jackson in the 1970s, and they developed a Maslach burnout inventory. So you can measure it, and it weighs the effect of emotional exhaustion and reduced sense of personal accomplishment. They compared it to depressive symptoms. There really is no difference. So the real difference is in the history. And we're focusing now on colleagues, and it includes nurses and other healthcare workers who, by virtue of their exposure to their work environment, have been impacted. That's where you have the difference in diagnosis. But diagnostically, there are no significant differences observed between the two groups. That is major depressive disorder for other reasons and burnout. So burnout workers reported as many depressive symptoms as clinically depressed patients. There is a concept of tolerance level. So we don't all burn out at the same time and to the same degree of severity. And that's a function of a couple of things: your support network, like family, colleagues, appropriate programs to assist you, your sense of control, and I'll go on to describe what sense of control contributes, your attitude and outlook, if you're thinking all is doom and gloom or not, your ability to deal with your emotions, mindfulness is a term that comes to mind, and your knowledge and preparation. So we are hoping that in addressing this subject now, your knowledge would be increased, and by virtue of that, your preparation improved. So all this research can be easily had through RAS feed, and that's not an expletive, but real simple syndication. So as opposed to searching stress, there's this RSS program which forwards based on your interest to you all things surrounding what you highlighted. I have stress in there, I have suicide in there, and so on. So you get these things. So it's an easy way to keep up with news information, consolidating information sources, especially if you engage in research. So it comes to you, you don't need to be searching for it. In these feeds, relatively recent study, 2022, burnout among general practitioners, a quantitative review of the literature, another one, orthopedic surgeons of a high prevalence of burnout. And it's in the middle of doing a presentation to the year twos in the medical school here. This one pops up in 2023. US surgeons are killing themselves at an alarming rate. And one who was the head of medicine in the US at the time, head of surgery rather, decided to speak out, and speak she did. and really highlighted the challenges in the system. Our own, God rest his soul, Dr. Lahey, Franklin Lahey, now deceased psychiatrist trained here, has a paper in the West Indian Medical Journal. It's a good read, 2005, where he speaks to the impaired physician, the only one I'm aware of written on the subject. And he highlighted that factors in our background, all of us, our personality and training, may contribute and predispose us to drug misuse and mental illness, particularly depression. So we have a strong drive for achievement, exceptional conscientiousness, ability to deny personal problems. So these may help your medical career, and the service you provide doesn't help you if you're not in control of these issues. And so it helps with your success in medicine. Ironically, however, they may predispose to impairment. Future Forum is an entity in the US, and they're looking at, it consists of millennials and Gen Z persons, looking at how those persons, millennials, Gen Z, are impacted by a number of things. Well, they looked in 2021 at burnout from workplace stress, and it was considered to be at an all-time high in 2021 of 10,000 plus full-time desk-based workers across the United States, across the United Kingdom. 40%. So that's almost a half. So that's 1 in 2 persons at a desk doing a job and doing it every day and exposed to burnout. So they recognize that burnout is on the rise worldwide, specifically millennials, Gen Zs. That's the bulk of our medical team anywhere in this country. And women are the most stressed. So just to take you through a very structured setting of phases of burnout, it doesn't all happen in one day. People start somewhere, and it's why I'm highlighting this, because all of us are likely to be somewhere on the spectrum. I'm listing 12 things. So you finish medical school, an internship and so on. You have a compulsion to prove yourself, and this desire turns into determination and compulsion. You're doing more. Number 2 phase, you're working harder. You have high personal expectations, and so does your family. You focus only on work, and this is a classic description. If you think back to your time as an intern. Some of us have children doing medicine or finished. It's exactly an exact description. You focus only on work. You take on more than you usually would. You show that, or attempt to show that you're irreplaceable. We're not. If we're not there tomorrow, someone else does the job. But this is generally how we perceive things, since you're able to do so much work without enlisting the help of others. So you're doing great. You're taking on more than you're even expected to do. Then comes phase 3, neglecting personal needs. Friends, family, they can't see you, they can't get you on the phone. You're missing meals. Sleeping starts to become seen as unnecessary. So you're getting by on 4 hours, 5 hours, and that can't be sustained. So these things become unimportant, but it worsens. So it's like a vortex. Phase 4, displacement of conflicts. You're unable to see the source of problems. People get into a crisis, and then you start having physical symptoms. People saying they're tired, pain everywhere. You then move on unless something happens, and it's checked to phase 5, where you're revising your values. You change your value system, so your job is your focus. So the job is okay, and the pressure you're under is okay. In fact, you want to expose yourself to more. You become isolated. Phase 6, denial of emerging problems. So you may recognize something is wrong. A close friend may have the opportunity, or a family member, to say, hey, slow down. We went through school together. I did engineering, you did medicine. And we maintain contact, and now can't get you. What's going on? We don't see anywhere. Then comes phase 7, withdrawal behavior. Alcohol or drugs may be sought out for release. You start having experiences of hopelessness. Phase 8, and it doesn't stop, the plot thickens. Obvious behavioral changes. Your co-workers start to recognize that you're a little snappy. They can't say anything to you. You're looking a little anxious. Family, friends. And then it worsens. Phase 9, depersonalization, where you're not in touch with yourself even. You're losing track of your personal needs. You may even look a little disheveled. So that iron shirt you used to wear, you're really not focusing so much on that. You may have forgotten to brush up your hair and so on. Real things. I see them every day in students and young interns. Life turns to a series of mechanical functions. You're just going through the paces. And then it worsens unless something happens to prevent that continuation. Inner emptiness, described as phase 10. Then comes depression, you're meeting the criteria. And then full-blown burnout syndrome, where you collapse physically, literally. And we do see that happening with interns, physicians, mid-career persons on the floor of the ward, and emotionally as well. And that now requires immediate medical attention. Unfortunately, if you're at that stage, suicidal ideation may occur. And we lose colleagues, as you all know, because that's part and parcel of an increased and severe burnout and even depression. Just listing briefly some of the sources of burnout at work, it would include lack of control, where that's actually most detrimental to health and morale. The high job demands in combination with low control. So you're not in control. It's happening around you. You don't have the resources that you need. Contrast is out in X-ray. They're doing limited CTs. I work at the University of the West Indies. Again, guys, don't misinterpret. So I'm not here to knock the system. I'm telling you how it is because I live it. I've done it for 27 years. Higher rates of coronary disease and depression than those in other categories, and we've listed the reference there. Values conflict. You then have insufficient reward, all characteristic features of what we're exposed to. Work overload, unfairness, because you don't know what's going on, but you recognize that you're doing blood work, you're getting back the CBC, but you can't get the UNEs because the machine is down and you don't know. People need to know what's going on. Nothing shuts down morale more than whispering behind closed doors. So you're just hearing little sus, little this, little that. Medimpex wasn't paid, so there's no stimulaton on the VEN list. Real things. Breakdown of community, patronizing colleagues, especially if you're in a DM program at our university, love it, and support the training. I'm the DM coordinator for psychiatry. But these are just difficult areas to continue to sustain yourself because of this breakdown in community. No mechanism for conflict resolution, feedback non-existent, you're pressured to press on, and in fact, you feel less than if you even think of complaining. No need to have a serious mismatch in all the 6 things I just listed. 1 is sufficient. So let me just go quickly back over those 6 things. Lack of control, values conflict, insufficient reward, work overload, unfairness, breakdown of community. Anyone, and there's a mismatch, is sufficient to put you on a path to burning out. Turning now to some coping strategies. So clearly, those would be divided into individual strategies and organizational. Managing stress, if you have to buy one book this year, here's the book. Written in 1995 by Newton. Excellent read. Emotion and Power at Work. I think I would highly recommend to all of you. And I have no business interest in this book. Many of the remedies related to burnout are motivated not from an employee's perspective, but from the organization's perspective. And because there are benefits to coping strategies, clearly what should follow is that both of these, individual and organizational attempts to adopt some burnout coping strategies, is most useful. Individual strategies would include, and this is a big topic, we don't intend to expand too much on any particular thing. I'm just touching on areas of importance. Access to mental health resources. So for example, if you're at the University of the West Indies, it is highly unlikely that you're going to be comfortable walking across to Ward 21 to see me because you're in surgery, you're in pathology. Why are you there? We call that stigma, and we understand it. And so somewhere like a University of the West Indies, like a KPH, should really have a psychiatric service where persons are not seen on compound, but outside. And it's one of the things that we recognize. And have to start somewhere, but these are proposals that certainly I have every interest in making. Mindfulness, stress reduction strategies, even going to the gym, for example, just a simple workout, doesn't have to be anything fancy, walking outdoors. Social support, still on individual aspects, one of the largest predictors toward a reduction in burnout and stress for workers. So engaging in some social activity, creating an organizationally supportive environment, as well as ensuring that employees have supporting work environments to mediate the negative aspects of burnout and stress. This is almost non-existent, harsh reality. Then comes stress management, and I won't spend a lot of time on this, but this is what I will focus on, taking care of yourself and making time for rest and relaxation. Very important. Who is going to do it if not you? And so this is a very important that we recognize this. So just to come back to control, we recognize that persons cope well. So Green Berets in the military, all of these special forces people, it's called the 3 C's, characteristic features of people who cope much better than average persons. First C is commitment to a personal goal. So you're committed to a cause, to something. Could be anything, but you're focused and zoned in. A personal view of being in control of your person, yourself, your environment. And the third C, you're seeing change as a challenge, not as the end of the world. So that's the 3 C's: commitment, being in control, and viewing what you're exposed to as a challenge. Moving to the organizational strategies, and again, in this silly season, this is not aimed at any administration, just repeating that. Balance workloads and scheduling, very important. So for example, where the head of a firm doesn't have a leave schedule, for example, that's a clear indication that people just not being focused on as they should be. You have a work schedule and you have your roster every month. Do we have a leave schedule in the department, for example? Supportive leadership and recognition programs, policies prioritizing staff well-being. These are some of the important organizational strategies. Employee assistance programs, and you're all familiar with this. Do we have enough? I don't think so. Stress management training is not intuitive. People need help and guidance. But the point I'm making is that individual component should allow you to seek this out. So nothing wrong in spending some of your earnings on your own well-being and getting some assistance. Stress interventions, very important. Just to list briefly some sources of help: family, friends, any religion is protective. A family doctor or Ministry of Health and Wellness, there's a helpline. However, do we have specific assistance programs? And so these are some of the areas that we could do a little more with, especially in these large facilities. The outcome of all I'm saying is that by combining personal and systemic approaches, it will build resilience, it prevents burnout, and supports compassionate, high-quality care for the person's weak feet. There is a study, and it's listed down below, a little old, a Mayo Clinic study, but very important, where they looked at US physicians by career stage. And what they recognize is that early career physicians are the lowest satisfaction with overall career choice. So I have people leaving medicine, the highest frequency of work-home conflicts, and the highest rates of depersonalization. So people become unwell. Physicians in middle career, so these are your DM guys now, in the middle of their program, worked more hours, took more overnight calls, had the lowest satisfaction with their specialty choice and their work-life balance, and the highest rates of emotional exhaustion and burnout. Middle career physicians most likely to plan to leave the practice of medicine for reasons other than retirement in the next 2 years. Men and women across all specialties and practice types. It didn't matter in this study which specialty it was, but some of them are tougher than others. One comes to mind: surgery, for example. Burnout, satisfaction, and other professional challenges for physicians vary by career stage. Mid-career appears to be a particularly challenging time. That's your Gen Z millennials, essentially. In conclusion, for that study, physicians face different challenges at different stages of their career. So you need to tailor things based on career positions. Middle career, particularly challenging. Strategies to improve work experience. Mid-career physicians are needed to maintain productivity, minimize turnover. That's the brain drain you're talking about. And improve patient care, especially if you're in a DM, for example, you're now exposed to a fellowship somewhere, they are going to keep you. We generally do well, and if that's recognized, they'll do everything to keep you. And that's what's going on. The message, therefore, is we need efforts to promote career satisfaction, reduce burnout, facilitate retention, need to be expanded beyond just early career. You need tailored career stages. And this is the only way that we'll prevent the current brain drain and the crisis that we face. It's not just in nursing, it's in medicine as well. All of us have colleagues who have gone to other pastures They may not always be greener, plus they're cold. Healthcare institutions, therefore, in closing, must cultivate environments which sustain provider well-being, enhance job satisfaction, to ultimately improve the delivery of compassionate, high-quality care. I'm closing now with just very briefly, just touching and moving. I happen to be one of the practitioners. It's not many of us, but there's a new frontier in psychiatry, profound implications for psychiatry. We have had few pharmacological advancements for treating mental disorders and addiction in the last 20 years. So we recognize the need for new therapeutic tools. It's a new era after decades of criminalization. Psychedelic drugs are on the cusp of entering mainstream psychiatry. We now have even FDA approval, albeit conditional, for MDMA and psilocybin as breakthrough therapies for PTSD, treatment-resistant depression, obsessive-compulsive disorder, and a couple of others. We do need all available and effective products. Psychedelic psychiatry has the potential to change the lives of millions of patients, reducing their disability and improving their quality of life. So these are products which, of all the products I use, antidepressants, anxiolytics, antipsychotics, where obviously they are indicated depending on the patient's presentation and diagnosis, this is the only one I'm aware of that even without an illness, and you meet the criteria, there are criteria, it's not for everyone, and not for all conditions, but where you can improve your general well-being by being exposed. So we really find this at this point as the way to stop surfing and start making waves. Psychedelic therapy, whether microdose or macrodose, frankly, I see colleagues around, and because I practice this aspect of psychiatry, you recognize that this particular person would do very well on a microdose, for example. But it's not a silver bullet. It's not for everyone. So you can achieve these states of, I'll use a term, enlightenment without psychedelics. Yogis, for example, are there, people with years of extreme introspection and keep providing answers to your own questions can achieve these states. That's not necessary. So I'll close just with some drawing of a patient who did a high dose with me relatively recently. Not an artist, not a graphic artist. In fact, it's a businessman. But these are some of the qualities enhanced by the psychedelics, who then went home. It was the first that this person was on this drawing tool on the computer and sent me this, and I have the person's permission to share it. But these are some of the phenomenal results that we're having. Persons going home to their families, being called Michael 1, pre-high dose, then Michael 2, post-high dose. So I'm just touching, just presenting. But the point I'm making is that we need to do everything in our power to avail ourselves of the ability to cope with the heavy work, and it's our choice. You don't have to, as I tell the medical students, but that's your choice. It's a good choice, and you're able to help others, but it's a tough setting. And so we need to be aware and have the mechanisms in place, including support, to ensure that we don't get sucked down into this vortex as we're all exposed and potentially engaged in order to survive and do well. So I want to thank you very much. We normally present and leave, but with Al presenting his presentation coming up, there's no way that I would leave, but I'll certainly wait to hear his presentation. And then in the end, we have a panel which we'll go through. I'm looking forward to seeing those results. I think it's a landmark study in terms of the results that we have of persons in Jamaica. Thank you very much.
Thank you very much, Dr. Delahaye. At this time, we'll ask Ms. Lisa Hubbard to bring the sponsor presentation spotlight.
For Stimulotan are depression, panic attacks, and... Good evening, ladies and gentlemen. This is Lisa Hubbard, one of the med reps here at Medimpex Jamaica Limited, where we distribute first-class products for healthy living. This evening, I'm going to be speaking about two of the products in our portfolio, Stimulotan and Polixid. The first one is our Stimulotan, which is our sertraline 50 milligrams, and it's a selective serotonin reuptake inhibitor, better known as an SSRI. So how do they work? They act within the brain to increase the amount of the neurotransmitter serotonin in the synaptic gap by inhibiting its reuptake. This helps to ease the symptoms of mood disorders such as depression and anxiety. So the indications for Stimulotan are depression, panic attacks, and obsessive compulsive disorders. So SSRIs have become the first choice treatment for depression owing to their excellent efficacy, safety profile, side effect profile, and onset of action. So how are they dosed? For depression and OCD, it's 50 milligrams once daily with food, and expect complete therapeutic effects after 2 to 4 weeks. For panic disorder, week 1 is 25 milligrams once daily with food, and Stimulotan is scored for you to achieve this dose. And week 2, it's 50 milligrams once daily with food. Complete therapeutic effects after 8 to 12 weeks. The maximum daily dose is 200 milligrams. As you all know, Stimulotan can be used for premature ejaculation, which is an off-label indication. So for that, it's 50 milligrams OD for 6 weeks, then when needed thereafter. And for prophylaxis, it's 50 milligrams PRN 2 hours prior to sexual intercourse. So dose adjustment, for the elderly, no dose reduction is necessary. For renal impairment, no modification of dose necessary. For hepatic impairment, a lower dose or the usual dose with longer dosage intervals. For pregnancy, safety has not been established, and for nursing, it isn't excreted in the breast milk. So the benefits of Stimulotan: sertraline is among the most potent SSRI. Age has no influence on sertraline clearance. Plasma levels and clearance can be quickly and effectively controlled, and it has a small effect on the CYP enzymes, thus reducing drug interactions. So Stimulotan offering choice to your patients. It retails at approximately $180 per tab, and with NHF subsidy for this drug, it's $44 per tab. The patient will pay approximately $136 per tab after NHF coverage. So Stimulotan, it lifts you out of depression. The second product I'm doing today is our Polixid, which is the Nepozyl hydrochloride, and it's available in 5 and 10 milligrams. So Polixid is used to treat dementia. There are many forms of dementia. The most common being Alzheimer's disease, frontotemporal dementia, vascular dementia, Parkinson's disease dementia, and Lewy body dementia. Alzheimer's disease is the most common cause of dementia. The term dementia describes a set of symptoms which can include loss of memory, mood changes, and problems with communication and reasoning. These symptoms occur when the brain is damaged by certain diseases and conditions, including Alzheimer's disease. People with Alzheimer's also have a shortage of some important chemicals in the brain. These chemicals are involved with the transmission of messages within the brain. Alzheimer's is a progressive disease, which means that gradually, over time, more parts of the brain are damaged, and as this happens, the symptoms become more severe. Top warning signs of Alzheimer's: recent memory loss affecting job, difficulty performing familiar tasks, problems with language, disorientation to time or place, poor or decreased judgment, problems with abstract thinking, misplacing things, changes in mood or behavior, changes in personality, and loss of initiative. So Alzheimer's disease is characterized by 2 abnormalities in the brain: the formation of amyloid plaques between the nerve cells and neurofibrillary tangle store within the neurons. And this is what a schematic looks like of a normal brain and Alzheimer's brain. All right, so Polixid, indications for it is for the treatment of mild to moderately severe Alzheimer's disease. The mechanism of action for Polixid, it's a cholinesterase inhibitor. It is a specific and reversible inhibitor of acetylcholinesterase, which is the predominant cholinesterase in the brain. The Nepozyl hydrochloride is postulated to exert its therapeutic effect by enhancing cholinergic function through increased concentrations of acetylcholine. There is no evidence that the Nepozyl alters the course of the underlying dementing process, however. It just helps to manage the symptoms of the disease. So the dosage. Initial dose is 5 milligrams once per day in the evening before retiring for at least 1 month. After 1 month assessment, the dose may be increased to 10 milligrams. The maximum daily dose is 10 milligrams. For those with renal and hepatic impairment, same dosing as clearance of the drug is not affected and is not recommended in children. So the presentations are a round wide biconflex film-coated tablets, and the Polixid 5 milligram, which comes in packs of 28, retails for $11,186 with a 40% markup. And the Polixid 10 milligram 28 retails for $12,684, also with a 40% markup. Very good news is that Polixid is now available on the VEN list, so it's available in the public system for free to the patients. So why the Nepozyl? Why Polixid? It's well tolerated. It improves cognition and functioning. You have a 38% reduction in functional decline, improves behavior symptoms. You can have some adverse effects, and they could be bradycardia, GI, muscle cramps, and fatigue. So thank you very much for your attention, ladies and gentlemen, and have a good evening.
Thank you very much, Lisa, for highlighting, putting spotlight on your products. Very important products that we use in conditions of dementia and in depression. All right, moving along. We're moving to the next session, the ethics session. And it gives me pleasure to introduce Dr. Alveston Bailey. Dr. Alveston Bailey is a distinguished Caribbean physician whose career reflects visionary leadership, academic excellence, and a deep commitment to public health and family medicine. As a regional president of the Caribbean College of Family Physicians from 2002 to 2006, he modernized its digital infrastructure, advanced interregional collaboration, and contributed to the development of accreditation standards and continuing education within the Caribbean Association of Medical Councils, CAMC. A founding member of the Caribbean College of Family Physicians, he also pioneered the CAREC Sentinel Surveillance System, enhancing regional disease monitoring. During his presidency of the Medical Association of Jamaica from 2005 to 2007, Dr. Bailey championed professional ethics, modernized the MAJ, Medical Association of Jamaica's Insurance Fund, and influenced national health policies on diabetes and hypertension. As a preceptor for the MSc Family Medicine program at the UWI and chair of the Medical Association of Jamaica's Foundation, he has mentored physicians and supported the welfare of medical colleagues. Dr. Bailey's scholarly and public contributions are significant, with over 50 presentations, authorship of sexplanation, and development of training manuals in occupational health. His media outreach through programs like On Call with Dr. Al and SexWise has enhanced public health literacy across the region. He has received numerous accolades, including the MAJ President's Award, the Caribbean College of Family Physicians Chairperson's Award, the Caribbean College of Family Physicians Fellowship, Sir Alistair McIntyre Distinguished Award in 2022 and the World Family Doctors Day Signature Award in 2024. Outside of medicine, he enjoys photography, poetry, and family life with his wife Clarissa, daughters Priscilla and Rochelle, and grandchildren. Dr. Bailey's legacy is one of service, scholarship, and advocacy, shaping Caribbean healthcare and inspiring generations of medical professionals. You know, Dr. Bailey, I'm so glad you were born. I am so happy that you were born because you have done quite a bit of paving the road for healthcare education, and medical training, not only in Jamaica, but across the region. And yes, it has impacted the world. So your work has been national, regional, and international. And I invite you to come now and speak to us on ethical challenges in self-care. Welcome, Dr. Alvaston Bailey.
Thank you very much, Alice. I trust that you can see my slide.
Yes, we can see your slide.
Okay, thank you very much. You're too kind. I had no idea that I'd done so much over the past few years. Time does fly. It really is a pleasure for me to be asked to make another presentation, Ethical Issues in Family Medicine. And I'd like to thank the AGPJ for inviting me again to make this presentation. And I'm extremely pleased to share this platform with my friend, Dr. Delahaye, who has worked with me for almost 3 decades. This particular topic is extremely important, and I congratulated the AGPJ for conceiving of the topic, and also just to let all of you bear in mind and remain posted in your seat, we did a survey. I prepared a questionnaire and sent it out to over 1,000 persons, and we got fairly good response with respect to that survey having to do with healthcare and self-care. And we'll be discussing the findings after I've completed my presentation, so please remain fixed in your position. This topic is described as ethical challenges in self-care, balancing professional duties with personal well-being. When I was asked to present this topic, an aphorism just went through my mind. And I went back to Luke 4, verse 23, which says, "Physician, heal thyself." The objectives of my presentation is to discuss what is self-care, to look at the impact of medical practice on physical health, the impact of medical practice on mental health, and I will not discuss burnout in this particular section. Then I'll take a look at ethical challenges in balancing healthcare with self-care. I'll present you some ethical scenarios which will be essentially applied bioethics. And then we will briefly mention some strategies for promoting physician self-care, and Dr. Dele went through most of those, and then I'll conclude. Now, if you look at this aphorism, this was published by the American Medical Association in 2021, so it's really new. It says, "Physicians, sustain thyself to safeguard others." And I particularly like it, and I just place it alone on this slide to emphasize this particular concept. Physician, sustain thyself to safeguard others. Now, medical ethics is a branch of applied ethics that equips healthcare professionals with moral principles to guide their practice, to do research, and to conduct themselves. It draws on long-established traditions and modern frameworks to support sound ethical decision-making and ensure that the well-being, rights, and dignity of patients is preserved. According to Bouchard et al., in the Principles of Biomedical Ethics, the four central values are autonomy, honoring patients' right to make informed choices; beneficence, acting in the patient's best interest; non-malfeasance, to do no harm; and justice. It is interesting when I apply these to doctors. You soon see the application of this not only to patients but to us. These are the pillars of medical ethics. Now, these principles provide us with a framework for balancing patient rights, clinical obligation, and societal consideration when conflicts arise. Now, I'm particularly interested in virtue ethics. I've been studying Stoic philosophy for the past year, and it has been quite transformative in that I've delved deeply into the concept of Stoic ethics, which I'll share with you. Because I think if we as physicians focus on virtue ethics, we will become better persons. It's a branch of moral philosophy which emphasizes the character of the moral agent rather than rules, which is deontology, or consequences, which is consequentialism. Virtue ethics asks some questions. What kind of person should I be rather than what should I do? Let me repeat that. It asks, what kind of person should I be rather than what should I do? And therefore, it emphasizes some major characteristics like courage, wisdom, honesty, temperance, and justice. And in my opinion, if we as physicians extol the virtues of courage, wisdom, honesty, temperance, and justice, we will do good to ourselves and to others. It is rooted in Aristotle's Nicomachean Ethics, which argues that the purpose of life is to achieve eudaimonia, which is a life well lived through the development of virtues. I strongly recommend that all of you listening take a good look at becoming virtuous. And this is my mentor, Aristotle. As I said, he emphasized wisdom, and it's interesting for me, the first one is wisdom, because you must be rational and sensible in your decisions, generosity, patience, and humility. So a virtuous person lives in accordance with these qualities. It has been revived in the 20th century by Elizabeth Anscombe, Philippa Foot, and Alasdair MacIntyre, and you can look up those if you're so inclined. So, virtue ethics therefore teach that living a morally good life involves cultivating ethics of wisdom, temperance, justice, and honesty. And therefore, it is less about following rules and more about becoming a good person who acts rightly because of who they are. And Marcus Aurelius says quite clearly, if it's not right, don't do it. If it is not true, don't say it. You will then become a good person. So what is self-care? Self-care is broadly defined by the WHO 2022 as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without the support of a healthcare provider. For physicians, self-care is more than a personal choice. It is a professional responsibility. I just want to repeat that. For us, self-care is more than a personal choice. It is a professional responsibility. It is essential for sustaining long-term clinical competence and ethical integrity. This was put forward by Shanafelt on his team in 2017. It encompasses physical, emotional, psychological, and spiritual well-being, and includes practices such as regular exercise, sleep hygiene, health nutrition, mindfulness, and seeking support. When we come into the discussion section, I would like Dr. Delahaye to delve a little deeper into the concept of mindfulness. And this particular, I don't want to pay particular attention to it because the results of the survey are extremely alarming in that it shows quite clearly that we are not taking enough exercise, we are not sleeping enough, we are not eating properly, and we are not seeking support. And in order for us to be regarded as being involved in appropriate self-care, we have to recognize that we need to do these things. Exercise, sleep, healthy nutrition, mindfulness, and seeking support. Now, there are a few physical impacts that medical practice imposes on us, and I'll go through these fairly quickly. Chronic stress and allostatic load, and I particularly like that term. Those of you who have not heard it, that's a new term. You need to consider allostatic load. Sleep deprivation, self-explanatory, musculoskeletal strain, and presenteeism. Physicians often deprioritize their own well-being due to beliefs such as perfectionism, invulnerability, or the need to be always available. We also tend to delay seeking medical help, especially for mental health concern, due to fear of professional stigma or licenses consequences, and Dr. Delahaye mentioned that. Let me tell you about chronic stress and allostatic load. Physicians working in high-pressure clinical environments often experience chronic stress that elevates allostatic load. What is allostatic load? It's the cumulative wear and tear to which the body is subjected due to excessive stress. This impacts on your neuroendocrine system. Dr. Delahaye mentioned HPA axis, your cardiovascular system, your immune system, and your metabolic system, leading to hypertension, accelerated atherogenesis, and impaired immune function. Therefore, if we are exposed to constant stress, it's a pathway to ill health. The BMA in 2021 stated that clinicians frequently exceed 60 hours work week, disrupting sleep, and therefore they are at risk of increasing cardiovascular and metabolic disease. We are making ourselves sick. Chronic sleep restriction has been shown to be linked to obesity, hypertension, diabetes, and metabolic syndrome. And this is rather sobering. All my research is basically hot off the press. Sun in 2022, in his paper, said individuals working over 60 hours per week face a substantial increased risk, substantial sounds like over 50%, of myocardial infarction and metabolic syndrome. Winston indicated a reluctance to comment on health strategies. But my take on the matter, and Winston and I have been involved in advocacy for years, is that if we are asked to work over 60 hours per week, we are inviting the possibility of early MI and metabolic disorders, and this is shown in Sonnetal 2022, and the various associations, therefore, should use this paper to advocate for reduction in the work hours because of the inherent risk. How about musculoskeletal strain? Now, that's my field because I'm in occupational health and safety, and prolonged standing, awkward postures like surgery, repetitive tasks contribute to chronic musculoskeletal complaint, especially in the neck, shoulders, back, wrists, and lower limbs. A study of over 6,000 medical personnel in China found that standing for prolonged periods, maintaining awkward postures was associated with significantly higher risk of developing all the known musculoskeletal disorders, such as back pain, leg discomfort, chronic fatigue, and the various arthritides and bursitis. Now, this concept of presenteeism is quite interesting because it means that you are reporting to work while you are ill. Unacceptable. A large majority of physicians, roughly 65 to 90%, report to work while they're ill, and that is not acceptable. And this is known as presenteeism. You are there, but you're not there in complete mind and body. And it's because you think you're indispensable, it is your duty, and it is a norm, and it is a pathway to ill health. So this practice not only increases your or decreases your clinical judgment, but enhances the possibility of transmitting infectious diseases to your patients and your colleagues. So the take-home point, if you're ill, you must not work, period. Now, some colleagues, of course, not only involved in presenteeism, they also self-medicate, and that is regarded as not acceptable because the rate of self-medication, this is published in American Association of Family Physicians, 2005, says that up to 50 to 8% of doctors self-medicate. We should seek help. The impact on mental health, Dr. Daly has discussed. I won't delve much on burnout. He went into a lot of detail about that. Just to remind you that the prevalence of depressive symptoms among physicians exceeds that of the general population. This particular concept of compassion fatigue, also known as secondary traumatic stress, affects up to 16 to 85% of healthcare workers, and this leads to a lot of problems. I worked for a few months at KPH, and I saw a large number of my colleagues in E&E experiencing emotional numbness, reduced empathy, and burnout. And if you find that you're developing compassion fatigue, you must go on some leave. You mustn't stay on the job. You could become dangerous. Moral stress. When systemic constraints, and Dr. Daly mentioned that, problems with supplies and equipment and the condition of work, prevents physicians from delivering best care. Moral distress ensues. You become unsatisfied, you become cynical, you become disengaged, and this is a systemic issue. And it can cause moral distress. So what are ethical challenges that we have to address? The Hippocratic Oath and principles such as beneficence, non-malfeasance, underscore the physician's duty to prioritize the welfare of patients. I'm going to read this slowly because bullet number 2, pay attention to this bullet, states, and this was published in 2017 in BMJ called Burnout Among Doctors. It says the ethics of self-sacrifice must be tempered with the reality that a depleted physician is an impaired physician. Let me repeat that. The ethics of self-care must be tempered with the reality that a depleted physician is an impaired physician. And that is a take-home point I want to leave with you. The AMA 2021 emphasized that physicians have an ethical obligation not only to care for patients, but also to maintain your own health to uphold the standard of care, i.e., if your health is impaired, your standards will fall. The prevailing culture, therefore, is for self-sacrifice, often interpreted as working long hours, skipping meals, or postponing personal care. However, AMA affirms that safeguarding patients' care requires clinicians to maintain their own well-being. Let me repeat, safeguarding patient care requires us to maintain our own well-being. The principles of beneficence acting in patients' best interests appears to justify self-neglect. Yet, prolonged self-neglect leads to burnout and will impair your judgment, and therefore compromising the very good that you are trying to do. Therefore, we must recognize, I'm actually giving you some take-home points I want you to kind of write them down. We must recognize that self-care is not a luxury, but a duty, rooted in non-malfeasance, do no harm. So self-care is not a luxury, but a duty, rooted in non-malfeasance, do no harm. Dr. Daly mentioned, no harm in repetition. Burnout is characterized by emotional exhaustion, depersonalization, and diminished sense of accomplishment. You become unhappy. And this would lead to ethical lapses, such as impaired empathy and disengagement from patients and errors. Should a physician continue treating patients while experiencing burnout? The answer is no. And AMA encourages physicians who experience burnout to seek help when needed, because failure to do so constitutes a breach of professional integrity and justice. You're being unfair. So physicians may resist prioritizing their health out of fear of being perceived as weak or less committed, a systemic problem. However, autonomy, the right to manage one's own life, must be balanced against the duty to maintain professional standards. A physician's choice to forego needed rest or mental health care may seem autonomous, but if that choice endangers patients, it becomes ethically untenable. Institutions must foster environments, therefore, that normalize and support physician self-care, reframing it as an ethical obligation than a personal indulgence. Many burnout drivers are systemic, like excessive documentation, long hours, inadequate staffing, and lack of support. Therefore, to reinforce Dr. Dele's point, justice demands that institutions share this responsibility. When healthcare systems fail to address work overload or mental health stigma, physicians bear an unfair ethical burden and cannot provide optimal care. And therefore, they should insist that their schedules are fair, they have access to counseling, and the administrative burden is reduced. I'm going to now share some case scenarios with you. I'll pause when I reach dilemma to give you at least 2 seconds to think about your response, and then I'll give you what is the appropriate ethical response. Dr. Patel, a consultant surgeon, has been on call for 36 hours and has performed 3 emergency surgeries back to back. Just as she prepares to take a much-needed rest, a 4th emergency arrives, a patient with acute appendicitis. Should she push through her fatigue and perform the surgery, knowing exhaustion impairs clinical judgment, or should she call in a less experienced doctor and compromise the patient outcome? The ethical issue we have to consider in this scenario is non-malfeasance, patient safety versus physician fatigue, and responsible delegation. The ethical response, therefore, must adhere to the principle of non-malfeasance. Fatigue impairs decision-making and fine motor skills, especially surgery, increasing the risk of surgical error. Operating while cognitively impaired violates the duty to do no harm. It also looks at the issue of beneficence. The patient requires immediate care. Delaying surgery could cause deterioration or death. The ethical course of action therefore recommended is Dr. Patel should assess the urgency and explore options. Consult a rested colleague if available, or request temporary support. If no other competent surgeon is available and the case is critical, she may ethically proceed, but this is a systemic issue due to no system being put in place by the hospitals for physician fatigue. Hospitals, therefore, must put in safeguards like staggered shifts and relief rosters to reduce moral distress and ensure patient safety. The reflection from this scenario is that the duty of care must be balanced with the right to be cared for. Case 2. Dr. Anderson, a pediatrician, just lost his child in a traffic accident. He returns to work a few days later to maintain continuity of care, but he finds himself emotionally unstable, especially when treating children with terminal condition. The dilemma is, should he continue working to avoid disrupting his practice and his patient's care, or should he take extended bereavement leave, knowing his emotional instability could affect his professional conduct? The ethical issues addresses emotional competence, duty to care versus duty to self, risk of impaired performance. The ethical response, therefore, should be based on the principle of professional competence. Emotional trauma can impair therapeutic empathy and decision-making. Physicians, therefore, must ensure they are fit to practice. Duty to self versus duty to patient. Continuing work under severe grief could compromise patient care and exacerbate personal suffering. Dr. Anderson should disclose his situation to his department and request leave or lighter duties. Confidentiality should be preserved. His peers should respect and support his choice. Temperance and prudence are needed. Recognizing our limitations is not weakness, colleagues, but wisdom. Compassion towards patient, therefore, must begin with compassion towards self. Case 3. The pregnant resident. Dr. Chen, the third-year OB/GYN resident, is in her third trimester. She is experiencing fatigue, swelling of her legs, and mild eclampsia, yet she continues to work long shifts. Worried about burdening her peers and falling behind in training. Should she request modified duties or early maternity leave, or continue working in an environment that could harm her and her unborn child? The ethical issue, therefore, has to do with personal safety versus professional responsibility. Issue of pregnancy-related accommodations and fairness in team dynamics. The principles of non-malfeasance is an issue here because continuing physically demanding shift risks harm to both Dr. Chen and her unborn child. Institutions have an ethical obligation to provide accommodation for pregnant staff without penalizing them academically or professionally. The ethical action recommended, therefore, is Dr. Chen should request modified duties or early leave. The program should offer flexibility without stigmatizing her. And bioethics perspective from a feminist point of view recognizes the need to accommodate gendered experiences and guard against institutional bias. The reflection from this ethical dilemma is caring for future physicians begins with valuing their well-being during training. Case 4, the mental health crisis. Dr. Wallace, and this one now should pique the curiosity of Dr. Delahaye. A psychiatrist has been silently struggling with major depressive disorder. He avoids treatment due to stigma and fear of professional repercussion. One day he breaks down during a session and cancels all his appointments. Should he disclose his condition to his institution and seek help, risking temporary suspension, or continue to hide it and return to work prematurely? The ethical issue is the physician mental health, patient trust, transparency versus self-protection, stigma, and system failure. The ethical response, therefore, depends on the principle of integrity and self-regulation. I put this one in blue because I wanted to jump at you. Physicians have an ethical duty to recognize impairments and withdraw from care temporarily if safety is compromised. The MA Code of Ethics argues that physicians should seek help for physical or mental illness, which assures confidentiality. Therefore, medical institutions must create environments where seeking mental health is normalized, not penalized. Therefore, the reflection from this case is to sustain the healer, we must first honor their humanity. Case 5, the ethical refusal. This is an interesting one. A family physician is recovering from MI. A long-term patient calls on her personal phone in distress, demanding a home visit for worsening COPD. But Dr. Morgan's cardiologist has asked her to rest. Should she visit the patient even though she might deteriorate without immediate care, or refuse a visit and refer the patient to another doctor? Well, you now have to address loyalty to patient, setting professional boundaries, and continuity of care versus physical recuperation of yourself. The ethical response is informed by the principle of autonomy and self-preservation. It argues that physicians have the right to refuse actions that compromise their health. Let me repeat that. Physicians have the right to refuse actions that compromise their health. The expectation of unending availability is ethically unsustainable. I'm going to repeat that. The expectation of unending availability is ethically unsustainable. While the patient is vulnerable, the request should be directed without guilt or breach of care to someone else. Dr. Morgan should explain the situation to the patient and arrange alternative care. A doctor should set boundaries grounded in honesty and mutual care. Case 6, Dr. Thomas, a 30-year-old emergency physician, develops a high fever, body ache, and cough, but feels obliged to report for duty due to poor staffing of the hospital. With a packed ER and no one readily available to cover, he dons a surgical mask and continues to see a few dozen patients. The ethical principle is one of non-malfeasance, beneficence, and professional responsibility. Though Dr. Thomas' dedication is admirable, working while symptomatic compromises his health and patient's health. He risks spreading infection and making errors due to fatigue and illness. Ethically, he should notify his supervisor and step away. Therefore, institutions must support such decisions by having contingency staffing and fostering a non-punitive culture if a physician becomes sick. Case 7, skipping breaks or meals during long shift. And this particular case was brought out clearly in the response in the survey. Dr. Alia, a second-year pediatric resident, routinely skips meals and breaks during her 24 hours calls because she feels that any delay in rounding or charting will compromise patient care. She experiences frequent headaches, irritability, and decreased concentration. Should Dr. Alia continue to skip meals and breaks? This involves 4 principles: non-malfeasance to yourself and to patients, justice, and professional integrity. While Dr. Alia's concern for timely care is valid, prolonged neglect of basic physiological needs can lead to cognitive errors and burnout. She has a duty to preserve her health to ensure safe, high-quality care. Ethically, her institution should promote structured breaks and educate trainees about sustainable work habits. And those of you who work in public institutions should make some notes here. So that when you have your meetings with the various associations, you advocate for the institution to institute these approaches to preserve your health. So supervisors must model and support self-care practices without guilt or fear of judgment. We're almost finished. Case 5. Dr. Reed, a 45-year-old internist, has become emotionally numb, sleeps poorly, and dreads going to work. This falls squarely in Dr. Delay's lap. He is making documentation errors. His colleagues notice his distress, and I want us to pause at this because I want to discuss it with Dr. Delay shortly, because in my opinion, every institution must put in place a fitness for work policy. And if you notice that your colleague is impaired, you ought to intervene and encourage him to cease and desist from working until he's better. And it's an arrangement that can be made, because we did it in the bauxite company, where workers that were obviously impaired because of the change in persona, the change in dress code, the change in other habits, were gently referred to an employee assistance program. So those colleagues notice his distress. He resists seeking psychological support, fearing stigma and licensing complication. The issue, therefore, has to do with autonomy, beneficence, and professional competence. Should he remain on the job, or should he be asked to take a break, or actively encouraged by his head of department? Untreated burnout and depression can lead to serious clinical consequences. We know that physicians have the autonomy to make personal health choices, but professional duty obliges Dr. Reed to seek care that maintain his clinical competence. But this care should be confidential, and I want to emphasize that. It can't be on-site, it has to be off-site. Licensing bodies and healthcare institutions therefore should ensure that mental health treatment is encouraged, not penalized, and it is not fitness to practice, it is wellness seeking. We're almost done. Case 9, being called to work while on scheduled leave, and I'm sure all of you have had this experience, or family leave. Dr. Chen, a 33-year-old OBGYN, is on a vacation in over a year, is on her first vacation rather, in over a year, spending time with her newborn. On day 3 of her leave, she receives a call from her department asking if she can return early to cover for a colleague out sick, and the request is framed as urgent. Ladies and gentlemen, colleagues, should Dr. Chen terminate her vacation, stop taking care of her newborn, and return to work? This involves the ethics of justice and fairness, respect for autonomy and beneficence. While helping a colleague in distress might seem noble, consistent disregard for your own personal time will undermine your well-being. Dr. Chen has a right to restorative time with her family and an obligation to avoid burnout. Therefore, in my opinion, ethically, she may decline if she is so moved. Hospitals must create robust systems for temporary coverage and foster a culture that respects boundaries and values physician wellness. The final case is saying no to extra clinical duties to pursue self-development. Dr. Walters, a 50-year-old cardiologist, is scheduled to attend the professional development seminar on emerging treatments for heart failure. Just before the seminar, the medical director asked him to cancel his attendance to cover an unexpected shortage in the cath lab. Should he, colleagues, cancel his attendance to deal with a shortage in the cath lab, or should he graciously decline? And if he declines, will he be punished? Will he be penalized? What do you think? The ethical principles here are professionalism, justice, and long-term beneficence. While urgent patient needs must be addressed, attending the seminar contributes to Dr. Walters' competence in future patient care. Ethically, it is justifiable for him to protect this time. Institutions should view continued education not as a luxury, but as a professional obligation. Therefore, the reflection is a fair workload distribution system must be in place, ensuring that doctors are not routinely forced to choose between long-term growth and immediate service. So, what do we do? Dr. Dele delved deeply into strategies for promoting physician self-care. But just to summarize them quickly, there must be organizational commitment to physician well-being. There must be workflow and workload reform. The institution must actively promote autonomy and professional agency. Institution must create psychological safety and peer support structures. Education, training, and awareness of the impact of stress on performance should be in place. Health-seeking behavior must be normalized. I want to repeat that. Health-seeking behavior must be normalized, and mental health care must be destigmatized. To prevent moral distress, there should be fair compensation and appropriate recognition system. So, in conclusion, the aphorism, physician, heal thyself, underscores a paradox within the medical profession. Those tasked with healing others often neglect themselves. Self-care is not a selfish act, but an ethical obligation that ensures physicians remain capable of delivering safe, compassionate, and competent care. Physician burnout is a moral, clinical, and systemic issue that threatens the very foundation of ethical healthcare delivery. By embedding physician well-being into the ethos of institutional practice, organizations can better uphold the ethical principles of non-malfeasance to avoid harm to patients and providers, beneficence to improve well-being, autonomy to respect personal and professional integrity and justice, fair treatment, and availability of appropriate resources. Therefore, a final point to you, colleagues. I gather that there are quite a few hundred colleagues that are online right now. And I want you to take a screenshot of this slide, which says, to fulfill the promise of medicine, systems must change, cultures must evolve. And finally, I'm going to say this slowly, physicians, I'm going to say it almost poetically, physicians must reclaim the right to care for themselves as fiercely as they care for others. I thank you. We will now invite the IT to project the survey, and I will introduce the results, and we'll now move into the panel discussion, and Dr. Della A and I will have a talk about the results. I am not sure I think we are doing fairly well. This session should have lasted until 10 o'clock, so we're doing fairly well. After the discussion, we could get some questions. I'm not sure. The night is fast spent. I'm sure Vincent will be staying with me.
I agree. And Al, I have my own 2 pence to add as well, you know, because
No problem.
I remember so many things that
No problem.
I would like to share.
No problem. So after we have the discussion, the floor will be open. Alice will direct that. So could you go back to the first, I designed this questionnaire and sent it out to participants in our senior activities that we have joined us over the years, and a large number of persons participated: civil servants, family physicians, general practitioners, nurses, registered nurses, and so on. Therefore, the response here really covers healthcare providers and not necessarily doctors, even though the majority were general practitioners, medical officers, and physicians. Please scroll up for me, sir. Scroll up for me. There you are. Okay, the first question is, how often do we feel overwhelmed by clinical duties? And this is an interesting one, in that the majority of respondents said sometime. And they respondents are coming in and hiding the slide. Surprised you could just adjust that for me, because I cannot see the last. They're coming in with their comments and interrupting my analysis. You could move it up. Move it up to the top for me, please. There you are. Fine, good, great. So you notice that the question is, how often do you feel overwhelmed by your clinical duties? And the majority said sometimes and often, so 50%. Winston, what's your take on this? Because it seems as if a large number of our colleagues are experiencing stress, but are they sharing the stress with their supervisors or with the institution? Because this is serious. 50%.
Yeah, very concerning, Al. And if you sum those together, it's close to 80% being between sometimes and always.
Okay,
so that's a great concern. A good next question, of course, always hindsight is 2020, would be to ask, has someone been made aware of their feeling? And I assure you that's probably hovers in around 80%, 90%. So they know what they feel based on the response, but I haven't said it to anyone. That's the challenge.
All right, so your recommendation then going forward, if 80% of healthcare providers are overwhelmed, what do they do?
And it's why I have a system of supervision. And so we should be able to advise supervisors. All systems in medicine have that, nursing, medicine, so that at the very least, there is recognition, some diagnostic suspicion, to then facilitate an assessment.
All right, thanks much. Please move up for me, Sam. Next question. All right. To what extent do you believe your work interferes with your ability to maintain your physical and mental health? Go right up for me, Sam. Go right up some more. There you are. To what extent do you believe your work experience interfere with your ability to maintain physical health and mental health? No, oh dear me. It seems as if a significant number believes that their work is impacting negatively on their physical and mental health. This, Vincent, is essentially similar to the first question, in that that they are experiencing physical and mental challenges, but do they disclose?
And I'll hasten to tell you, my feeling is no. And so that's a challenge. So it means a vast majority is struggling with no recognition, or even if you had a program, because you haven't reached out, even if you had, it's not always available, but even if you did, then they wouldn't be able to access that because they're not seeking help. It's one of the challenges. Yeah.
All right. The next one, Sam. Therefore, I find this one really interesting. I want us to dwell on this a bit. Which of the following self-care areas do you find most difficult to maintain due to professional obligation? I was not pleased with this response because it means you have a problem. If you combine physical exercise and recreation facility, it means that physicians are not having any fun. And not only that, if you notice that a significant number is having sleep issue, and a significant number is not eating properly, so they are not exercising, they're not taking time out to go to the beach and have some fun, go to some festival where you want to go to, but they're also not eating properly and they're not sleeping properly. Again, this indicates we have a problem because some of the intervention strategies, some of the stress relieving methodologies that we recommend are not being pursued by healthcare providers. Could it be that they do not know what to do, or they feel reluctant to do it?
So I mean, again, very concerning. I mean, and thus far, all the slides you have showed, and the harsh reality here is that this isn't sustainable. So it's a matter of time before anyone presenting with these complaints will succumb. But then the more I'm looking at what you're presenting, Al, the more I'm thinking it shouldn't wait for internship and, being in a program to really, we need to, for the medical students, start to identify these challenges because they're all at risk of falling prey to this based on the work that we do. So I teach a second all the years. I'm not so sure there's a program there really highlighting this. There is one I teach called the Impaired Physician, where we get to touch on it. It's a 90-minute class. It's just not sufficient, but in the same way you're scheduled for duties, you should be guided in scheduling your recreation, your exercise. And it's on you to really determine that, but it can be encouraged by the system.
Okay, wait, so you and I have had a discussion prior to this, that this kind of data must be made available to policymakers because it's compelling. That and as you said, during my many years in the public sector, I can't recall there being any time out for recreation or exercise. And in fact, in most cases, we just had a snack on the go. And I can't recall any time out being put aside for you to get some rest. So this indicates that some of the key stress management modalities are not being observed by healthcare providers. Please scroll up for me, Sam. There you are. Now, this says, have you ever delayed or avoided seeking medical or psychological care for yourself due to professional commitment? And and oh Lord, it says yes, yes, okay, 60%, roughly. See, why is that so, Winston?
Well, as precisely why we're having the presentation. So we are of the view that we should only be focused on providing care, not necessarily take care of ourselves. So it's a mental health shift that's required for persons to be aware and implement what's required to stay healthy. And it clearly must be that in terms of priority, we recognize that unless we are well, then we can't be well enough to care for persons who are unwell.
Okay. Move up for me, Sam. Now let's look at coping mechanism. I find this one really interesting now. No. We gave, in my survey, we gave the respondents a whole lot of options. Friends, families, socializing, listening to music, reading, watching movies, taking break time off, peer support group, physical activity, spiritual practices, professional counseling, and meditation. I found it quite interesting that a significant number were involved in spiritual practices. Now, that's not my area of expertise, but I sense that because we have such a large number of non-physicians in the survey, that might be weighted towards the non-physician, because I'm not sure if most of the physicians I know do not use spiritual practices for stress management. The other one they mentioned was meditation and mindfulness. I thought this was particularly high because we were never taught meditation and mindfulness in medical school. And therefore, I'm really wondering if the concept of mindfulness and medication in this instance was really what at this stage of my life I know is mindfulness. But what do you think they mean by mindfulness here?
And it's not intuitive. I don't think they understood the question,
Okay.
Because this is not everyday knowledge. But of concern to me, Al, is professional counseling, 12%.
Ouch.
And
Yes.
so, people just not aware that engaging with a professional just to guide you through, and facilitate ventilation, probably assist you in decision making is very useful. It's what it would suggest.
And
So
it
it's not
also
on their radar.
it also bothers me, Winston. If you look at taking time off, the majority, that's what they do. But time off doesn't mean stress management, does it?
Not sufficient. Absolutely not.
And I was really intrigued by the paucity of response with respect to friends and family, because we know that connecting with friends and family increases your oxytocin level and definitely makes a significant difference to your mental health. But very few people seem to be connecting with friends and family.
And that's isolation right there, which I made reference to. So you're really setting yourself up, for further decline.
And so essentially then, as you said, we need to start dealing with this matter from medical school years, because the key health stress management tools that most persons who lead a life of contentment use are not being used by the colleagues. And I have no problem with spiritual practices, but at least it should be as much as, if not, our professional counseling should at least be a significant part in this, and so we need to address that. Move up for me, Sam. All right. How supported do you feel your institution or workplace is in maintaining your well-being? Now, this is interesting. Not at all. Neutral. That's almost 60. Somewhat, basically 80. In other words, this is saying that the institution is not supporting the well-being of
not good enough. Not good enough.
And so when we publish this paper, we're going to have a meeting with the policymakers to address this issue, because
Yeah.
this is self-explanatory. Only 13% said very supported, and the rest says either not, somewhat neutral, or not at all. Please move up from it, Sam. Does your workplace provide structured wellness or self-care program for physicians? And a whopping
Yep.
80%.
That pie chart is shouting at you
Yes.
that something is wrong.
Right. Richard, you have been at the highest level of administration. Does the Ministry of Health have a employee assistance program in hospitals?
I'm sure there's some semblance, Al, it's just not sufficient. But more importantly, you have some not sures. So that's not something that you would have available, and we're not all aware. So there
Okay.
needs to be education, and that can be easily done through organizations like this very one, where you advise persons if it is that things are available. But this, for example, is something you'd want to be tracking every 6 months to make adjustments to improve this. It's no way that an administration would want to leave this as is or close.
All right. And the downside of not having structured wellness or self-care programs would be? That's question addressed to you, Winston. What is
the downside of
not having structured wellness or self-care programs? What's the
and
downside?
so what ends up happening is unwell persons are getting worse and not being able to provide adequate. The presenteeism you made reference to.
Yeah.
So you're there, but you're just not 100% functional.
Okay. So we have a lot of work to do. Move up for me, Sam. 8. All right. How supported do you feel in maintaining your well-being as a self-employed physician? That has to do with most of us, through peer networks, professional organization, family or staff, and somewhat neutral, not at all. So I'm to gather here that self-employed physicians need help.
Not engaging. And
Yes,
it must be through organizations that we get things out and pull people in, for their own benefit.
So therefore, isolationism definitely is detrimental to your well-being, because I mentioned peer network, professional, and as I mentioned before, there seemed to very little involvement with family or friends. And if they're not involved with family or friends, and they're not part of organizations, a part of network, they're isolated. And whatever problems they have will just mushroom out of control. So it's a matter that has to be addressed. Move up from it, Sam. Number 9. We almost finished. As a self-employed physician, do you intentionally schedule time or allocate resources for personal well-being, stress management, or professional self-care? I find this particularly funny. I knew what the answer would be, because the answer is rarely, occasionally. Yes, only 20% said yes. The others says occasionally and rarely. So again, self-care is not a major issue for physicians then.
Just not on the horizon, and there lies a challenge, because you don't even know that you're neglecting yourself. It is why knowledge of this needs to be disseminated so persons are aware,
All right. Move up from me, Sam. Section C. Do you feel a moral or ethical conflict when prioritizing your own health over patient care? Now, this is a very interesting slide, because it means that most colleagues are conflicted when they are taking care of patients who are unwell, but they are also so unwell. And I see here only 21% so they never have a moral conflict. The majority of physicians worry about not taking care of a patient even when they're unwell. So
and this is one that can be easily adjusted. So, for
Yeah.
example, educational interventions like this very presentation, better yet, workshops, aimed at this, can really improve that kind of knowledge for persons to recognize that there's nothing wrong. In fact, it's a requirement for you to be able to sustain, and be able to provide adequate service for your patients. So
In
these are
fact-
things that we really can work on and improve.
Okay, in fact, I can't forgetting this mantra by Venerable Professor Abel, which says, "It's okay not to feel okay," which
Yep.
we don't like the idea of saying to ourselves, "You're not okay."
No, not
Right.
all.
And if you're not okay, I'm sure if you were to state clearly to the patient or to your super that you're not okay today, they will be willing to listen to you. And so you're not okay, and you go to work and you're not performing at your best self, and you could cause harm. Move up for me, Sam. We're almost finished. Oh, I'm not going to get into that. So essentially, in summary, Winston, your take on this survey?
I think it's very clear that there are problems that we can't sit back and allow. We have some contribution that we can make with a forum like this. It's not everything, but at the very least, in terms of representation as an organized body, to present the findings to the powers that be. So even if they did not request this assessment, obviously they haven't, we are able to take this to them to say this is not acceptable. And of course, including like the Medical Association of Jamaica in these kinds of findings of this nature to get the appropriate representation. Because the harsh reality is we're the ones, as I say, who feels it knows it. And so you have to shout it. Not blocking roads, of course, but there are other methods, in an acceptable way of making your voice heard and getting the help that you need and the adjustments required in the workplace.
Thank you very much. Okay, so we've come to the end of a panel discussion. I think Aldith has some comments to make, and she might invite some of the delegates to ask appropriate questions, and then we will respond. Over to you, Aldith. Sam, where's Aldith? Oh, there she is.
Yes, sorry, yes. Well, thank you so much, Winston and Al. It was quite a stimulating overview of the poll that you did. And it's quite revealing that there's a lot of things that need to sort out. What is glaring is that there's urgency and agency for systems change. The system is broken. And we cannot continue like this. If we want a different outcome where physicians feel human, then we have to sort out the systems that are in place. Now, I remember when I was an intern at KPH, I really enjoyed my internship. I had wonderful persons working with. And when I was on Dr. Knox Hagley's firm, I realized that people were not taking any breaks, these long ward rounds. And I said, no, I got to change something here. So I had a strategy, and it was through food that I made sure to make my drinks, I make my sandwiches, and I just came prepared. And I told Dr. Hagley, Dr. Hagley, in between the wards, let's just take a 5 to 10 minute break. Is that okay? Because I have prepared wonderful refreshments. And his face just lit up, and he said, really, Bucky? That's good. I said, yeah. So we did one round, we did one ward, and then we took a break, both the nurses and the doctors and the interns. And they drank their tamarind juice and they had their sandwiches. And we could chat and we could laugh. And it was just wonderful. And then we had the next ward to do. So you don't have to wait for the system to change. You can be an agent of change. Sometimes what happens is that people or the powers that be may not see what you see, but you're feeling it. So just speak to the person in charge of your, say, doing the ward rounds. Sir, can we do what this? So I just showed you what I did and it worked. And everybody just loved it, including me, because it allowed all of us to get a refreshment break and we were better able to serve our patients even better. So we served ourselves and we served our patients. Yeah, so that was fun. And then a time came when when the residents went off on leave because they had exams. And that just left me as the only intern with Dr. Hadley. And I had 80 patients on this ward and 80 patients on the other ward. And yeah, I kept working. But then there came a time when I looked at myself in the mirror and I said, Buckland, you don't look good. So I went to Dr. Hadley and I said, Dr. Hadley, I said, yes, Bucky. Look at my eyes. He said, I'm looking at your eyes. What am I supposed to see? That man is wise, you know. He says, what am I supposed to see? So I said, sir, my eyes are not sparkling. Okay, your eyes are not sparkling. What does that mean? Sir, I'm exhausted. I feel it right in my bones. You know, Dr. Hadley, I feel like I'm just going to faint on this floor, you know, and I don't think it's going to look good if I just fainted on the floor. He said, no, okay, you get 3 days sick leave. And he wrote me up of 3 days sick leave. But he knows I was not making it because I really, really work hard. And he gave me 3 days sick leave. And trust me, I slept and I slept and I slept. And when I got up, like Lazarus from the grave, and I went to the ward, my consultant's eyes were bloodshot red. And he said, Buckland, you are a sight for sore eyes. He had sore eyes. He did all my duties. I tell you, he's such a gentle giant. I respect him so much. I will never, ever forget his kindnesses because he was human. And I am human, but I was able to ask, seek, and knock. The scripture said, ask and it shall be given to you. Seek and ye shall find, knock and the door will be open unto you. So stop being afraid. I know the system is such that you feel afraid to ask. Guess what? Stop it. Just stand your ground and say your piece. Ask. Because then you become a change agent. If you go on with the stupid flow as things are, things will never change. Everybody's going to continue suffering. Stop it and let's do something about it, right? So let's all be change agents. So we need to be really, really aware of how we are feeling. That is a mental checkup. Just check, how am I feeling today? And then you want to check your mind. You have a bad mind or you have a good mind? Check that out, too, you know, bad mind or good mind. Then you have to check your exercise. The exercise is tonic. When you exercise regularly, you're going to find that you get stronger and stronger. And it is fun because I just make sure I walk at least 45 minutes a day. Even if the sun is shining, I'm going to walk with my umbrella because as I walk along, I wave to my neighbors and we have a chat and go along. And there's a place called Rooster Mountain. I just love to go to Rooster Mountain because when I go to Rooster Mountain, I see the rooster, I see the chickens, I see the hen. And my God, they are such a family, they take care of each other. Even the little animals know to take care of each other. Why can't we? But they are aware. We need to be aware. What has happened is that we have normalized abuse. We can see our fellow brother and sister doctor suffering, but because we say, oh, we go through it, so they must go through it too. Stop it. That's wrong. You're normalizing abuse. you know, thank God the Ministry of Health and Wellness, they have put out these national screening guidelines for priority NCDs in Jamaica. And they cover 7 priority NCDs, and one of them is depression. And it goes through the life course from when you're this to when you're that, from when you're born to when you're ready to drop down dead, right? And they go through the life course and what we need to look for. We, as Dr. Al has shown, have significant risk factors, but we can do something about the risk. If we don't do something about the risk, we are shortening our lives. Who does that benefit? Stop it. We can do something different, right? So what you're going to do different, I'm going to tell you about SHIELD, S-H-I-E-L-D. Have your SHIELD on. What is SHIELD? S is sleep. When you get a good night's sleep, when you wake up, you feel good. And yes, you may find that you wake up and you go back to sleep. But guess what? Each sleep cycle is 90 minutes, you know. So when you wake up, it's a sleep cycle that just finished. Go back to your bed, man. If you find that you have trouble sleeping, guess what? Do not turn on your smart device, because when you turn on the light now and you start watching this something, the light has shut off your sleep switch, because light shuts off the switch. When you have light, you see how God made nature. The light is for working and the night is for sleeping. The darkness is a sleep switch. When we are in darkness, we sleep better. When we are in light, we're going to wake up. So when you stimulate your mind, when you stimulate, the eyes are stimulated and it goes through whatever. And you turn on your sleep switch when you wake up. And then it's when you have trouble sleeping. Put this quarantine, put this to bed somewhere. No, don't put it beside you. You're not supposed to be beside you. Put it far. You need to sleep too. Okay? S-H-I-E-L-D. Sleep. Just sleep. If you finally wake up, then guess what? Count from 1,000 backwards and count aloud. 1,999, 998, 900. Say it aloud. You don't say it in your head. 997, 900. And it works. Just count backwards aloud. And have fun with it, because you're going to be, and you will experiment on yourself and you find you fall back to sleep. But please put these devices that emanate light far from you. S, sleep. H, help for stress. Help for stress, one way is to sleep, because in sleep we restore our body and our mind. But there's another way. This is called havening touch. Take a breath and be aware that you're breathing in and breathing out. So did you know breathing in and breathing out is a meditation? But you've got to be aware. Be aware of your breath and be aware that you're breathing in. Breathe in, breathe out. In. Aren't you aware of that? It means you're conscious, right? In and out. And you practice being aware that you're breathing in and out. And you're going to find that you get more and more relaxed. Yes, it works. You can, if you really feel extremely stressed, apart from breathing in and out and being aware that you're breathing in and you're breathing out and following your breath in and following your breath out. As you do that, you can gently stroke your arms, just like how you pet a kitty. If you've never petted a kitty, then pet yourself, right? It's just a gentle touch. It's called a havening touch. But what it does, it induces delta waves. And then these delta waves are going to short circuit the AMPA receptors that causes stress in the amygdala. So it potentiates, it phosphorylates these AMPA receptors so that you feel more relaxed. You know, the amygdala is this place where you have a lot of your adrenaline. So if you feel stressed in this moment, you know, first, just right now, imagine, just bring up something that really disturbed or if you're stressed about today. It happened today. breathe in and breathe out. And then keep the image in your mind, breathing in and out, and just gently do this. And you can also do this. And you can also massage yourself. Because you are, you're touching yourself, and then they touch, they're sending signals to the amygdala to calm it. You see how good it feels. You love to go to the hairdresser, or you just love to get a massage, but that's a reason. There's a reason for it. God made us this way. You're wonderfully made. Wonderfully made. So sleep, help for stress. So help for stress is in sleep. It's in your breath, breathing in, and being aware, breathing in and out. And in self-havening, right? And you can just do this. And wash your hands before you even touch your face. But you can show your patients these simple things. Practice on yourself, and you find it works. Then you can show your patients, and they're going to say, my God, doctor. Because when the patient leaves, versus when it feels like you took off a burden. This is before you even put a tablet or give them a prescription. It works. Sleep helps for stress. And there are other helps for stress, right? As I said, help for stress, one way is really to just take a good walk. I just love to walk. When I walk, literally meditate, and sometimes I'm just, when you walk, you just clear your mind, or it's like you have an aha moment. Oh, why didn't I think about that before? Because you get away from the things that you were bogging you down, and you do something different. We must do something different, right? Love yourself, man. Sleep help for stress. How you interact with yourself and how you interact with others. Is interaction. A lot of stress is caused by how we interact with each other, and we need to interact with care and compassion for ourselves and for another person. How can you help another person? How can you show compassion to another person and you can't show compassion for yourself? The scripture says something. And I know, you talk about the scripture. I just firmly believe in what I believe. And it says, first command, love the Lord thy God with all thy heart, all thy soul, all thy mind, all thy strength. Right? And there is a reason, because I know there's a higher power. When I'm feeling really stressed out, I say, Lord, hold my hand. And there's a reason, because I have proven him over and over. If you don't prove him over and over, then I guess you have nothing to rely on. But I have proven my Lord over and over. So I said, Lord, hold my hand. Even if there is a situation, I remember a patient came in, and it's like I wrote a prescription, and then patient left, and I said, no, that is not right. And I said, Lord, what is this? And it's like this voice was talking to me. I'm not hearing voices, but I'm talking to myself. And like it says, what does that look like? And I said, it looked like scarlet skin, burned skin. And he said, what did medicine call it? It's like a burn. I said, oh, scarlet skin syndrome. I realized that I wrote the wrong thing for the person. And I called the patient back. I said, come. I have a sample of the medication. And the person came back. And I got the prescription for her kid, because there's another kid at home who had the same problem. Right? But you want to really, really stay connected to Almighty power. Do not let go of that Almighty power. There is a bigger power than you. And if you do not understand that, you're losing out on a lot. So sleep helps for stress. Interact into how you interact with yourself, how you interact with others, how you interact with the Almighty. Exercise. I told you about exercise already. Just do it. It is tonic. It is not something that you're going to fit in. You just do it. And you don't have to, you can go to the gym, but I just love to walk. I just do what I love to do. L is new learning. In not all learning, learn something new. Even if I want to maybe go on YouTube and learn how to do a certain dance, learn to do a dance, and I can do it in my own space. So sleep, help for stress. I is interaction, how I interact with myself, how I interact with others, how I interact with God. E is exercise, L is new learning, and D, diet. Guess what? Get off the fast food. It's not good for you. It is not good for you. It is cutting off your life. And you want to just make sure that you just stick close to nature, stick to what God made, and you eat that. God don't make it, you don't eat it. No, good for you. I'm good for you. Okay? God don't make it, you don't put it in your mouth. SHIELD. And remember that you must, as we interact with others, we must learn to be a support for others. And you must be willing to be a support for yourself. Just as you give, you must learn to receive. Sometimes we just love to give and think that we are not to receive. If it is so important that we learn to give thanks when other people love you. They reach out in their own way. And you don't say, oh, it's okay, because they get pleasure in saying thanks. And give your patients and give your family and give your colleagues the pleasure of thanking you for being there for them. And then also give them the pleasure of being there for you. Because you think that you want to fight this battle on your own and you think you must not ask. You are not giving your consultant the pleasure to say, yes, I can help you. I can give you time out. You just ask, seek, and knock. We need to be agents for change. Until the flipping system change, we got to be agents for change. I decided I wanted a break between the ward rounds. I decided I'm going to make the refreshments for everybody, because then everybody can get a break. When they get a break, I get a break. Yes. You must do that. Look in the mirror, and if you don't look right, something is wrong. Yeah, don't bother put on the makeup or whatever. Look in the mirror at yourself properly and fix it. You can fix it. So please do not continue the abuse. You know, the other day, as part of this WhatsApp group, I'm just talk about it. Because, the person said something that was really not right. Because they said something about me that is the opposite of what it was. And I said, you got to correct it. And the person decided, took long to say anything. You know, justice delayed is justice denied. And it was also a breach of data protection. And I asked for the thing to be corrected. And because I kept asking for correction, the other people in the group thought that I was being a bother. I am just asking for a correction. And if the person goes on, and you see what happened is that the other persons in the group don't understand that I am being abused by not correcting something and showing the correction to the group. You are doing an abuse, and I will not stand for it. There are some things that I value, and I value truth, and I think people need to be honest. And if you think you're being abused, I think you need to stand. Just stand up. Because what the person did was remove me out of the group. So to silence me. And that is an abuse. And I spoke to the data protection officer for MAG, and the person said that's an abuse. It's a reportable offense. Stand for yourself. Just stand up for yourself. Because you know right from wrong, and sometimes other people don't. I think what happened is fear. And I spoke to the person as nicely as I can, but still refused to do the correction. Okay. And all she has to do is make up her own little something and put the opposite of what she put in the flipping WhatsApp. Yeah, so we have to be careful how we do the WhatsApp. You know, I'm very glad that in Jamaica, we have the Data Protection Act. And although we went through a lot of stress being trained in data protection, I'm glad we did it. Because of all the islands, Jamaica is shining. No, we are shining because we are upholding our patients' rights, and we're also upholding our rights, right? But please do not normalize abuse. Just remember, shield, sleep, help for stress, how we interact with ourselves, how we interact with others, and how we interact with the Almighty. Exercise, new learning, and diet. And remember, stick to the natural way. If you fail to take care of yourself, you're going to reap the rewards of complications. Yeah. Let me go to the question and answer. That was really my 2 pence, but we're not going to normalize abuse of power. And what happened is that sometimes people are into something and they don't know any better. If people don't know any better, they just don't know any better. You can't ask a leopard to change his spots. If you see something, then you just engage in some conversation and change it. I did what I could so I could get a break when I was at KPH, and I really enjoyed KPH. It was the place to be. Really, really warm. Anyway, let me get to the questions. All right. Does the undergraduate medical training currently include any courses or classes or regular activities designed intentionally for teaching the students any practices that build their capacity to maintain their own mental health? I got to say no. Because that system continues. Am I right or am I right? Or am I wrong and am I wrong? Dr. Al or Dr. Delahaye, you can answer.
Okay, I think Delay has left us. I can't answer that question because I've been out of the system for decades. So
Yeah, nothing has changed. It continues. So nothing else. There needs to be urgency. There needs to be urgency and agency for system change. The same thing for planetary health. The man keeps abusing the planet, and nothing will change unless we see the urgency in recognizing that healthy people and healthy planet are hand in hand. So the same thing, if you want a healthy working place, we need to be the agents of change and do something about it. Because sometimes, and then we can maybe put in something, or we help them to put in something that will actually work temporarily until something can work. But yeah, but there has to be urgency and agency for system change. Next one here. But so my answer to that is no. What recourse does a doctor have to address being penalized for refusing to give up leave they are entitled to take in order to cover shortages in staff? In practice, we often concede these demands because we fear, hear the word fear again, retribution if we refuse, and losing one's job may be a bigger mental health challenge than giving up attending a continuing education seminar. You are so right. So you have to use your wisdom here. And that means that there's a shortage in the system. Al, you can respond to that, please.
Okay, as I said in my presentation,
Yeah, you did.
it's a major challenge because the system, in many instances, especially in postgrad training program, doesn't accommodate that kind of flexibility. So it will only change if the residents lobby for change. And one of the benefits of this discussion we're having and the fact that we did this survey is that we now have data which should help to inform policy decisions. So we hope that coming out of this discussion, we'll be able to at least start the process of change. But as you said, as a self-sacrifice has been ingrained in us, and I graduated decades ago, and I was told that medicine involves self-sacrifice and hard work. And if you indicate that you have some specific needs that need to be addressed, you're said to be soft and not up to if the heat is too hot in the kitchen, you need to get out, let's say. But that is insensitivity and abuse. But we can only experience change if we lobby for change. So I think the time has come now for us to start the process.
Yeah, I so agree with you. We can use use wisdom. However, lobby as agents of change, will lobby for it so that it happens, because we don't want this to be a recurring decimal. Next one. Could similar presentation be geared toward pharmacists as well? Of course. Mental health care issues should be introduced in schools from primary up to tertiary level. I so agree with you, as there is so much taboo. As a result, lots of persons deny when help is needed. Yeah, I agree with you. All right. Do you think non-medical hospital staff, especially administrators, should be aware of these stresses and behave appropriately? Huh? I agree. I find that they tend to be indifferent to the health of physicians. Yeah, because they're unaware. So we really actually need to improve their awareness. Maybe they need to work along with their doctor and understand what goes on. I remember working at KPH in the late 80s with poor working conditions and being severely understaffed. My blood pressure went to 60 upon 40. And I was constantly tired and frustrated. I resigned. It was the best decision I ever made. I salute you, sir. Keep in mind Dr. Hagley's red eyes. In parts of our system, there is little relief for the supervisors too. What then? Exactly. He was captain of the ship. Yeah. Yeah, I tell you, these we have giants, you know. How to treat mild bilateral parietal lobe atrophy? You know, that you mentioned that when we find that some persons are reticent and they refuse to change, sometimes we need to organize a brain scan because maybe they have something wrong upstairs and maybe they actually lose processing ability. Think about that one. So if you find that certain things are happening, we really have to do a mental checkup of the people who are in power. And some of them may need to do some scanning. Because how can they be over us and there's something wrong upstairs? They have to go through their wellness and they have to go through their fitness. And as Al said, we are not to penalize people for wellness. Sam, there is a little video clip that I asked you to put up. I sent it to you. You saw it? It has been so wonderful. While Sam is looking for that, it's in the WhatsApp, Sam. Well, I just so pleased with the Agpj team. The Agpj team is Dr. Donald Gordon, who is the president, and Dr. Peter Swaby, and Dr. Peggy Myers Morgan, and Dr. Aileen. Sorry. Oh my God, I don't believe it. Oh, Dr. Aileen. Yeah, and I'm Dr. Buckland, and they have Dr. Lynn Thompson. I didn't realize she was a doctor. She has her doctorate in administration. Such a wonderful support. But if anybody really needs to reach out to any of us, we're always there for you. We're
Ready
always
when you're
there,
ready,
whatever
Doc.
the stresses are. You're ready, Sam?
Yes, I am.
Okay, nice. Hi, I'm Dr. Aldith Buckland from the Caribbean College of Family Physicians. No, it's the wrong one. Advocating for health. So it's the wrong one.
Okay, let me see.
The last one I sent, sorry.
Sent another one. Sure.
Yes, I sent another one to you no WhatsApp. And what it was, just Monday, we had the national screening guidelines for priority NCDs in Jamaica launched. And the Association of General Practitioners actually endorses the Ministry of Health and Wellness guidelines. And I got a copy on Monday. So I'm going to ask Linny to, every time I think about Lynn, I just think about such wonderful support, and that she actually loads it up onto our website so that you guys can download it. And depression is on it, and it shows you how to go through the screening. So it was actually updated in 2024, so it was being launched. You found it? And
Let's try again.
yeah, okay.
Let's see if this is it.
I'm Dr. Aldith Buckland, Vice President of the Association of General Practitioners of Jamaica, endorsing the National Screening Guidelines for priority NCDs in Jamaica. These guidelines were developed by the Ministry of Health and Wellness in order to reduce the burden of NCDs in Jamaica. Also, let us know our numbers for blood pressure, sugar, cholesterol, BMI to determine our health status. Knowing our numbers and tracking these numbers over time tells us if we are making progress to becoming healthy. Everyone in Jamaica has a role to play in reducing the burden of NCDs. So join us, get screened, know your numbers, and make positive lifestyle changes today. Know your numbers. Thank you. Okay, good. So everybody can see this? You can see my screen? So you see this? Sam, you see my screen here?
Yes, Doc. Seeing the
Okay,
screen.
so this is us. This is the doctors, you see? We are on this downward trajectory because we're so flipping stressed out. We need to make sure we put on our shield and get back on this track if we want to have a wonderful life. We're not going on this anymore. Put on your shield, get your shield, and be the agent for change in your area. Make your juice, make your sandwich, do whatever so you can get a break. They're not doing it for you, so you do it. All right? And then you get up here and then you go on this track. Let us do something different so that we can be agents of change for ourselves and for the system. Yes. And now I invite Miss Melanie Miller, medical rep from Medimpex, to wrap up and do the vote of thanks.
Good evening, everyone. On behalf of the organizing committee, I would like to sincerely thank each and every one of you for making today's meeting a success. A heartfelt thanks to our distinguished speakers for sharing their expertise, insights, and valuable time with us. Your presentations have not only deepened our understanding, but have also challenged us to reflect more compassionately and conscientiously in our daily activities. Your contributions have not only enriched our knowledge, but have also inspired us to continue striving for excellence in patient care. I extend my gratitude to all the doctors and healthcare professionals present here for your active participation and thoughtful discussions. It is your engagement that makes these gatherings meaningful and impactful. Special thanks to the organizing team and support staff whose dedication behind the scenes ensure that today's program ran smoothly. We appreciate our partner, Agpj, for their unwavering support in making this meeting possible. Finally, I thank each of you for your valuable time and for honoring us with your presence. We trust that the knowledge gained today will inspire continued collaboration and innovation in our collective mission to improve healthcare outcomes. Thank you once again for being here and for your continued commitment in advancing healthcare. Wishing you all continued success in your practice. Good evening. Thank you.
Good evening. Thanks, Melanie. Thanks, Dr. Buckland. Thanks to Lynn and everyone at Agpj, and of course, thanks to our presenters tonight, Prof. Bailey, and of course, Dr. Delehe Ardenite. Everybody, thank you so much for joining. 1,700 of you registered, and I'm pretty sure based on the register that we're seeing some numbers close to that. Amazing numbers. Thank you, Medimpex. We look forward to the next one. Stay safe. Have a great evening and happy holiday. Bye, everybody.